This is my only pictorial slide. Rest of it is data. So before I go further, I have to tell you something about CDiff. This morning I was reading the New York Times book review. And I don't know how familiar many of you are with John Green. John Green wrote a bestseller called The Fault Is in Our Stars. It was made into a big Hollywood blockbuster. Well, he's just come out with his new book, which is getting rave reviews. It's about a teenager with severe obsessive compulsive disorder who is looking for an elusive multimillionaire. That's the plot of the book. Her obsessions are with CDiff. That's what obsesses her. So I'm going to read you from the New York Times book review. It says, but her repetitive, intrusive thoughts are her true torment. She's obsessed with and repulsed by the ecosystem of bacteria that seeds inside her and the bacteria that live without. She can't stop worrying about the rumble in her gut or the breeding microbes therein or the possibility of contracting an infection involving Clostridium difficile or the prospect of sweating or of not touching or of stopping sweating or touching anybody who is sweating. She has to fight off the insistent, unignorable thought to put hand sanitizer in her mouth. Sometimes the urge wins. So CDiff has now made it to popular culture. And you'll be hearing about this from your patients. And there's a lot of excitement, and for good reason. So why are we all so excited about CDiff? As you can see, those of us who practice in the hospital know that we are truly facing an epidemic. Over the last decade, the incidence rates has doubled, the case fatality rate has doubled, the cost has increased somewhere about $3 billion. And we're starting to see this virulent strain called NAP1B1027 started in Canada and over the last decade has spread worldwide. And this is the strain of CDiff that leads your patients to the ICU, to colectomy. It's unique because it's very resistant to fluoroquinolone. So a single dose of Levaquin will kill all the healthy bacteria and allow this to flourish. That is its identifying hallmark. And the toxin production is several-fold more than normal, and that's what makes it so virulent. So, reflux, colon cancer, obesity, these are a big deal. But I have to tell you this, all of us, especially physicians, nurses, are one antibiotic away from CDiff. And if you get the first attack, you get a 30% chance of recurrence. If you get a second attack, your rate of recurrence is 48%. Third attack, you're in my clinic for a fecal transplant. So this is an epidemic that touches all of us. We are, in fact, the highest risk group for fecal transplant, for CDiff recurrence. So what happens to the colonic microbiota? What causes recurrence? The main thing that happens is patients with recurrent CDiff have something called dysbiosis. For this, you have to go back to basic biology, but there are two large phyla that commonly make 80 to 90% of your gut bacteria, and these are Bacteroides and Firmicutes. In patients with CDiff, the amount and the variety of bacteria in these two phyla drop significantly, and commensal bacteria like proteobacteria and acinetobacteria then increase. There is some evidence that there is a disruption in bile acid, and we'll talk about this later in terms of new treatments. So if you do a fecal transplant, what you basically do is reverse this dysbiosis. And this lasts for a long time. The current data is 4 to 6 months, but some people believe this may be lifelong. In other words, you never go back to the microbiome that you were born with. So, who gets fecal transplant? The FDA approved indication is 3 episodes, That is, a primary episode followed by 2 recurrences, or 2 fulminant episodes. Fulminant episode being 2 severe episodes, defined as being admitted to the hospital, and or 1 fulminant episode. There are some people who are doing fecal transplant for people who don't respond to standard antibiotic therapy, to vancomycin. And that's emerging. It's still not FDA approved, so you have to have a long conversation with patients before you do that. And as you have probably heard, fecal transplant is being looked at for a number of diseases. I get calls once a week with somebody with multiple sclerosis, Parkinson's disease, who's very overweight, even metabolic syndrome. There is now enough data that the way to look at the human body is that, as you know, we have 10 times the number of bacterial cells and human cells. I look at the human body as basically a spaceship. We are their transport. And that's why they influence almost every single aspect of our metabolism and existence. Recently, the last Red Journal in GI had exciting study where 2 patients with alopecia areata, they had recurrent CDiff, they got a fecal transplant, and they went from being bald. If you've seen patients with alopecia areata, they have no hair, to a thick head of hair in 6 months. So, exciting therapy for guys with male pattern baldness. So it's amazing how many different aspects are being interviewed. So Dr. Lankarani talked about bariatrics. 20% of the weight loss and gastric bypass is because their colonic bacteria changes. There are some elegant studies where they took patients, and the patients who did not lose weight, it turns out their gastric bypass did not alter their microbiome in their colon. So it's a little bit like the Wild West. You don't know where you're going to find the gold or oil, but somebody's going to, it's coming. So this is an older slide. There are 2 ways you can do fecal transplant. You can take a donor, screen that person, and do it. I'm not doing much of this anymore, but there are some people who occasionally want somebody known to them. And this is the screening protocol. You basically do blood work and stool studies, look for infectious pathogens that can be potentially transmitted through stool, and then they donate the stool, or the transplant material as I like to call it, and you transplant it via colonoscopy, upper endoscopy, or flexible sigmoidoscopy. This is what I'm using mostly. There is a bank in Boston. It was founded in 2012 by an MIT graduate whose best friend got C. diff. And despite repeated attacks, he would not get better. So he and his friend moved heaven and earth, and they did the fecal transplant. This was about 15 years ago. And he realized that nobody else has this kind of resources. So they started a stool bank. And that is now the pioneer bank. And that's where we get our fecal transplant material from. It costs about $400 for the transplant material and $250 for shipping. At Borland-Groover, we always have 5 transplant available. We've already prepaid for them. And it's thawed at room temperature and then transplanted. Once you do a fecal transplant, we follow our patients for about 2 years. I've had my first patient about 6 years ago, and I'm still following her. So that you learn interesting things about, whether they have any potential long-term side effects. So how is it done? Well, fecal transplant can be done through the upper scope, through a nasoduodenal tube, and via enema or colonoscopy. I think gastroenterologists have done a great job selling colonoscopies to patients, so I find it very difficult to convince patients to have it by any other route. They tell me, just put me to sleep and do whatever you want to. So it's more acceptable, and that's being shown in studies. Patients like the colonoscopy route. There is some evidence that it's the most effective way of doing a fecal transplant. So, if they have a live donor, they collect the stool specimen on the morning of the procedure. They're prepped like a regular colonoscopy. They're given Imodium. and you give about 100 to 300 grams of stool. 100 is emerging as the target amount for most of our patients. And this is a very impressive slide. Are there any side effects? I've been practicing medicine for about 30 years, but I have never seen a medicine that has a 92% effectiveness and no side effects. I have yet to see a medicine like that. So there are really no major side effects of FMT. Patients do complain of some bloating and cramping as the microbiota take over. There has been one report of a UC flare in a patient. We don't know if it was related or not. 4 patients with autoimmune disease were reported, but the incidence was not any higher compared to normal controls. And the only death from a fecal transplant was as a result of the colonoscopy. So it's a very safe procedure. And there's a recent large study from MD Anderson which showed that severely immunocompromised patients could get a fecal transplant, whether they're on chemotherapy or not, their C. diff goes away. So immunosuppression is not a contraindication for fecal transplant. So does it work? Diarrhea goes away in 3 days, and the published success rate, this is across all the FMT studies in the United States, is about 92%. At Borland-Groover Clinic, our success rate is about 96%. The cure lasts months, even years. Patients can go back on antibiotics. Patients can go back on chemotherapy. They can go back on immunosuppressive medication if that was held, and it's very effective. The interesting thing is, the statistically significant difference between all three, how you do the transplant, is very similar. As I said, for enemas, the success rate is the lowest. It's about 82%. Highest for colonoscopy, about 92%. But it doesn't matter how you do it. At least for C. diff, this works. So 97% of patients who've had FMT for recurrent C. diff would do it again. Patients are very happy. These are my favorite patients. They always come in and hug me. None of my IBD patients or reflux patients ever hug me. All my C. diff patients do. 53% would prefer it as their first treatment. They suffered for months and years using recurrent therapy. And more than 3/4 would pay for it out of their own pocket. We charge them for the transplant material and a little bit for the colonoscopy. Patients write the check as soon as they leave my clinic. They see the effectiveness, the cost effectiveness of this therapy. So just keep in mind, a 12-day course of vancomycin is about $2,000. A 10-day course of Difficile is about $2,800. So it's very cost effective. Okay, so that's about FMT. Since my topic was what's new and what's coming along, I'm going to cover a few additional areas. This is the new kid on the block, Zimplava. It's a human monoclonal antibody that binds to toxin B and neutralizes it. It's a single dose and is given intravenously over 6 minutes. You have to give an additional anti-C. diff antibiotic with it. There were 2 phase 3 clinical trials, and it was much more effective than placebo in preventing a recurrence. Side effects were minimal. There was 1 report of congestive heart failure worsening. That's the only contraindication, and it costs about $4,000. I have yet to use it, but I can see it may play a role for a patient with severe C. diff. This is his 3rd attack. He's in the hospital, and before he goes home, you give him a prescription for oral vancomycin and 1 dose of Zimplava. I do not know about insurance coverage, but it is available on the market as of now. Future treatments. There are 3 vaccines currently being studied. The Sanofi vaccine is against toxin A and B, and it's in phase 3 studies. The Pfizer product is also in phase 3 studies, and there is a French company called Valneva, and they have a phase 3 study. All these vaccines are very effective, and the only downside to vaccination is you pretty much have to immunize every patient that gets admitted to the hospital, because that's your highest risk population. And that's a large number of patients, Safety has been very good, but cost effectiveness is something that's being discussed. But vaccines are coming your way. And as primary care physicians, I think you'll be using vaccines a lot more. You'll be offering it to your patients who are at high risk for CDiff. In FMT, this is the most exciting thing. Oral capsulated FMT. No more colonoscopy, no sedation. So the Open Biome, the stool bank in Boston, has an capsulated FMT which they give out on case-by-case basis. It's basically 30 capsules. You swallow 2 dummy, you come into Borland-Groover clinic, we register you, you swallow 2 dummy capsules, then you swallow either all 30 at once or do 15 over 2 days. And it's very effective. And I'd like to put in a plug for Borland-Groover research. We have, as of now, 2 of the most cutting-edge capsule FMT research. We have a study which uses the entire microbiome, freeze-dried capsulated stool, and it's a randomized double-blind phase 2 study, and we're currently enrolling patients. So if you have any patients with recurrent C. diff, please call Borland-Groover Clinic Research or myself and be happy to enroll you. And the second study is EcoSpore. This company, what they did was, instead of using the entire colonic microbiome, they took just the sporulating bacteria, killed all the bacteria and purified their spores. So 99.9% of all the bacteria are killed. And they take only their spores, they capsulate it, and in their initial study, they had a response rates about 84%. And here I have to put in a plug for Borland-Groover research also. The same company used capsulated FMT for ulcerative colitis, and the results were released last week, and they are very impressive. I can't tell you the data, but it will be published in the next few months. So the same product given on a daily basis for 8 weeks induces clinical endoscopic and clinical remission in many patients with ulcerative colitis. What's coming down the pike? If you go to clinicaltrials.gov, there are 169 C. diff studies currently listed on clinicaltrials.gov. We were also participant in RBX 7457, which is an enema study. Enema studies are very popular in Canada, in other countries where cost effectiveness is a big deal. In the US, patient acceptance of enemas is not that great, and you require 2 enemas. But this product is also in a phase 3 study for C. diff. There was a toxin-binding resin similar to Questran, which has been studied, but a recent meta-analysis of information was not very promising, so that's kind of going away. IVIG is available. Purified IVIG from healthy adults who've been exposed to C. diff works, but it's only available as part of a clinical trial. And a new antibiotic called teicoplanin is available. It's as effective as vancomycin and Flagyl. It's currently not available in the US. So what else is coming down the road? The same company that used the spores from sporulating fecal bacteria, what they have found is that you don't actually have to transplant all the bacteria. Out of the millions of species, there are only about 17 that are critical to C. diff. So what they're doing now is they're growing these 17 bacteria in watts in their laboratory. And the next product that they're going to develop will come from spores grown in the lab. Industrialization, no stool, no human being, no screening involved. So it's and this is a very exciting area because as I told you before, FMT is being used to treat a wide variety of diseases, but we don't know which bacteria is important in which disease, and by able to purify separate, we may be able to find clues about where they might be effective. And then there are some exciting studies using non-toxigenic Clostridium species to prevent C. diff. So that's what's coming, and I'd like to end by a quote by George Carlin, one of my favorites. He said, "Don't worry about the future too much. It's going to be a thing of the past soon." Thank you.